Welcome, everyone. This is Dr. Nadim Galou. I'm the Senior Medical Director with Abbott Structural Heart, and we welcome you this evening to our continuing webinar series focused on coordinators and the role that coordinators play. In fact, today's talk is titled The Coordinator's Key Role in Leading the Charge with Navitor. I'm an interventional cardiologist, and I practiced for 25 years, primarily doing structural heart interventions in the Washington metropolitan area. And now I'm in the current role and very happy to be here with you all today. When I was in practice, what I can tell you is that my coordinator was instrumental in everything that I did. In fact, they had a more centered and probably more substantive relationship with the patient prior to the procedure than even I did. I would be in there, of course, to have all the appropriate discussions as a physician should, but really the main conduit for information exchange and the pre-procedural management of the patient, including the medical therapy and all the appropriate evaluations, were done by my coordinator. The subsequent post-procedure management was likewise primarily managed by our coordinator. So shout out to all the coordinators out there. I think this is really, without a successful coordinator, cannot have a structural heart program. They're really the center of the entire program. And with that introduction, I want to introduce our speaker. But before I do that, I do want to say that we were to have two speakers tonight, but Santina Sperling from UPMT could not join us due to unforeseen circumstances, but we are very privileged and honored to have Dr. Yasmina Katenic as our guest today and as our speaker. Dr. Katenic is a nurse practitioner with 20 years of experience in the cardiovascular space, including patient care and healthcare leadership. Her background encompasses all aspects of cardiovascular care, from management to education in the cardiovascular intensive care unit to being a pioneer in the structural heart realm, including being a participant in the initial TAVI trials that really got all of this going. In her current role, she oversees all aspects of guideline-directed patient-centered care for structural heart and vascular patients in the West Florida division of the HCA system. She is integral to the multidisciplinary heart teams for innovative and novel transcatheter-based therapies. Dr. Katenic works closely with nurse practitioners, physicians, clinical trialists, and administrators at her program, providing evidence-based care, but also things that are also important, such as making sure that the program is financially viable and sound. She's been instrumental in the growth of structural heart programs, standardization, and implementation of patient-centered processes and adherence to both CMS and other regulatory established guidelines. It's truly an honor to have you. Thank you so much, and I'm going to hand the mic over to you.
Thank you, Dr. Galou. Really appreciate the introduction, and thank you for the partnership tonight. Look forward to the education. All right, so these are the disclosures for the program, and we are very honored actually to have Abbott sponsoring this educational event. Again, this is Santina, unfortunately, was not able to participate, so we will go ahead and do the presentation with the objectives of covering the aortic stenosis, etiology, pathophysiology, and the disease state, valvular heart disease, and the guidelines, including the CMS and the NCD, heart team and risk assessment, the device by Abbott and the FDA-approved indications, the role of the coordinator in multidisciplinary valvular heart disease clinic, case studies, and then we will open it to discussions for everybody. So we are here today to actually discuss aortic stenosis. We know that aortic stenosis is a disease of the aging population, actually causing the narrowing of the aortic valve that actually progresses through stages A, B, and C, and D, and causes ultimately symptoms that our patients experience. When the patients develop symptoms, usually starting in stage D of the severe symptomatic aortic stenosis, those usually stages will go through D1, D2, and D3 categorizations. And I will actually discuss that a little bit further as we discuss the guidelines. What is important to know is that actually the prevalence of the aging population and aortic stenosis disease is actually growing. And according to Dr. Genero and et al. That actually published an article in JACC in 2023, there is actually 44.9% of the patients that will actually die within 4 years if there is no intervention performed on the aortic valve stenosis. And what really is puzzling to the community for many of us that have been actually doing this procedure for a long time is that despite all of the education and the advancements in the technology and the treatment of the aortic stenosis, we still see this underdiagnosed and undertreated patient population. So looking at the CMS and the guidelines, the importance of touching on this, because this is actually geared towards the valve clinic coordinators, the structural heart coordinators, is that when we actually evaluate our patient, we have to start evaluating patients within the premises of multiple different expectations for your program, including following the guidelines. One of the guidelines that it's actually set by the CMS, it's actually your programmatic guidelines and which patients you can currently treat with the CMS indications. So the CMS says that the TAVR is covered under the treatment of symptomatic aortic valve stenosis when furnished according to an FDA-approved indication. So looking at the FDA-approved indication, starting first with how the guidelines define severe symptomatic aortic stenosis. So it is defined actually again by the D1, D2, and D3 criteria. And for, of course, more details, if you do have a phone that you can scan, please go ahead and scan the guidelines. But the D1 is your classic aortic stenosis where you have the peak velocity of 4, your mean gradient is over 40 or more. You have AVA of 1 or AVA index of 0.6. You have normal preserved ejection fraction. And again, those patients are pretty easy to actually recognize that they have severe aortic stenosis. The D2 and D3 criteria is actually reserved for the patients, especially for D2, if you have low ejection fraction, but you have AVA of 1.0 or less, and your gradients or velocities are not matching, you will of course look for those patients to see if they require the butamine stress echocardiogram to raise the gradients. And then if they do, they will meet that criteria. And then the D3, which is our paradoxical low flow, low gradient aortic stenosis patients, is actually patients that have probably the stroke volume index of less than 35 milliliters per meter square. And those patients actually will meet the severity of AS criteria. Those 3 buckets are pretty defined, but of course you will have patients who don't fit within those 3 categories. So this is where the heart team comes in place. And you as a heart team and the coordinators that are part of the heart team discussion, you will actually be able to weigh in and describe your patient's symptoms and find, what is the primary cause of their symptoms. So moving on further to kind of dissect a little bit of that FDA-approved indication. So talking about the Navitor transcatheter aortic valve implantation system, the Navitor valve is actually approved for patients who have severe symptomatic aortic stenosis and are classified as high risk based on their STS risk calculator or other reasons why the heart team would deem them high risk. Looking at specifically, what is important to remember when we look at the guidelines, when the guidelines were originally published, the guidelines actually stated that for the frailty, you need actually 2 frailty to call a patient high risk. Well, the guidelines were actually updated in September of 2024 with a correction to the high risk indication. So the frailty that was stated initially 2 or less has been changed now to 1 or more indices that will actually meet the high risk indication. So then how do you look at your patients as a heart team? when you complete all of the testing and you assess your patient and you calculate the STS, these are the ways that you can actually determine the risk factors. If your patient has STS of 8, that meets immediately high risk indication. But if your patient presents, with the STS less than 8%, you will then look, does your patient have one frailty? Or does your patient have one organ system dysfunction or anatomical consideration, which then would equal to high risk consideration? So what are the examples of major organ system compromise? Those are usually severe LV systolic or diastolic dysfunction or RV dysfunction. You can have fixed pulmonary hypertension, kidney dysfunction, usually stage 3 or worse, pulmonary dysfunction, FEV1 less than 50%, or DLCO less than 50% of predicted. You can actually have central nervous system dysfunction like dementia and Alzheimer's disease, Parkinson's disease, CVA, or persistent physical limitation. Our patients are usually older, so they will come with other limitations that will prevent them from having actually reasonable recovery after any procedure we do. You can actually have patients that are immunocompromised, that have malignancy, liver dysfunction. Again, doing a thorough assessment is really important because that's how we determine the real true risk factor of our patients. Some of the examples of anatomical consideration is actually procedure-specific impediments, including presence of tracheostomy or heavily calcified ascending aorta, what we call usually porcelain aorta, any chest malformation, previous radiation, if the patient had previous open heart surgery, and the coronary artery grafts, what is the proximity of those grafts to the sternum and how risky that procedure would be actually performing another sternotomy. So again, the importance of really assigning the correct risk to your patient is actually truly driven by what the shared decision with the patient will look like, what that conversation will be, not just in the light of assigning patient a Navitor device. It's actually truly, guiding you to have that conversation with the patient and what the potential for recovery and rehabilitation will look like. So again, moving further on the guidelines, it's really the guidelines in this format, which are slightly modified and adopted from the original guidelines. It just, showing when our patients come through the clinic and are being evaluated for severe aortic stenosis, we do actually consider all modality for the patient. And it's important that when the heart team looks at everything, that they actually determine whether the patient is a surgical candidate, whether the patient is a TAVI candidate, and potentially palliative therapy as really the only option available for the patient. And of course, also looking at, do they meet the severity of aortic stenosis, which then will determine whether the patient will need to wait and come back when the symptoms present or when the disease progresses. So what are some of the common tests that we do in the structural heart clinic? Of course, we always start with the echocardiogram, making sure that the patient has the disease so that we can progress with further evaluation. We will also look at the cardiac catheterization, look at the coronary angiography, making sure that the patient's symptoms are not actually related to coronary artery disease. We're going to look at the carotid ultrasound. We're going to do the electrocardiogram, understanding what is the risk of the patient needing the pacemaker potentially. We're going to actually look at the pulmonary function test, understanding the lung disease, and again, talking about, what that risk factor is on our patient. Really understanding the pulmonary function test helps. And, labs, frailty assessment, which we will talk just a little bit about more. And then the CT scan. CT scan is extremely important in the setting of determining what valve we're going to use, what is going to be our approach, and do we have anything that we need to worry during the procedure on our patient. So frailty, and again, this is, in my sites, I oversee 8 programs, and in our 8 programs, we still continue to follow the composite frailty score, which actually utilizes the 4 frailty indices: grip strength, 5-meter walk test. We use CATs of ADLs, and then the albumin level, which is usually less than 3.5. So these are the parameters based on men versus women, then based on their height and their BMI, and then we will determine whether the patient has actually frailty factor. And the true really frailty assessment helps us understand what type of potential for rehab they will have after any procedure we do. And even though the TAVI procedure is fairly low risk, again, it's very fast, patients recover really good from the TAVI procedures, we still get patients who are deconditioned, and we need to understand what that recovery will look for them, that recovery path, and if the path requires for them to go to rehab, or maybe require home health, just because they will need more recovery and more rehabilitation post-procedure. So those are some of the things that our frailty assessment helps us, in addition to understanding the true risk factor. So looking again at CMS, and again, I'm tying CMS a lot to how we take care of the patient, because again, that's important factor for all of the coordinators. And the CMS still requires us to have a heart team, right? That has to be a cohesive, multidisciplinary team of medical professionals that are usually defined by CMS, like the cardiac surgeon, interventional cardiologist, other providers, other physician groups, as well as actually patient practitioners, nurses, research personnel, administrators, the technicians. The team goes on and on and on. Again, we are a big team, and the coordinators that work in my program work very closely with everybody that's on that team. And the heart team responsibility is, and this is the entire team, is to actually look at the guidelines, look what is FDA approved, what are the CMS requirements, and then also how, when we participate in the registry, what are the registry expectations. So when we take care of the patient, we have to continuously keep that in the back of our mind as we are deciding what therapy we're going to offer our patients with severe symptomatic aortic stenosis. So, the importance of the structural heart coordinators, especially that are APPs, you guys are part of the patient evaluation process. So you will be part of making sure that you have pertinent medical record and medical history, surgical history, that you do a physical examination, understand that heart failure acuity, was all the testing performed, help actually interpret and understand, the imaging results. Is there something that we have uncovered? Again, very, very common. We take care of a lot of patients in their 70s and 80s, and there will be something that we will find that they may have never seen before. And all of that, again, testing and evaluation it's actually going to lead us to the shared decision-making process. That process should always be centered. There should be a heart team consensus when we actually talk to the patient on what that shared decision is looking like. And then we're going to use shared decision-making tools like cardiasmart.org. We will incorporate something that's unbiased, that is published, that is well-researched, and point patients to potentially even do their own research utilizing that website. We will also make sure that the heart team is part of the procedure planning. Very important step, and again, the coordinators are a critical component to that, making sure that the team comes together and ensures that they review all the pertinent data and results that were collected on these patients. And then, procedure execution, we ensure that the team is ready for the procedure. We make sure that, our schedules are aligned, that we have the coverage that we need for the procedure. And if you have a potentially very complex patient, do you need other disciplines to actually be part of your procedure? So again, the coordinators are critical in this, ensuring that we orchestrate this whole, musical team that is taking care of the patient. And then, as Dr. Galou just stated earlier, post-procedure care. A lot of our structural heart patients actually come back to see our valve clinic advanced practice providers. And the APPs are critical in making sure that all the follow-up is completed in a timely manner for the registry purposes, as well as, making sure that the patients are doing well. So again, going back to the heart team, again, CMS says, you really have to have a cohesive multidisciplinary team. So the cohesiveness of that team is documented through the heart team recommendation. There are multiple different ways of how you're going to document your heart team recommendation. There will be electronic medical record, potentially you have a paper record that everybody signs. So you know your team and you know your programs and the processes that you have in place. And as long as you follow those and you're consistent and referring physicians have access to see those recommendations, it's going to be critical to ensuring that everybody's involved in that patient care. So we're not going to elaborate on the details of the rest of the NCD, but we do know there are things that your hospital and your physicians have to meet to actually even perform a procedure like TAVR. And so those details, you can go on the website, for the decision memo for transcatheter aortic valve replacement. It's the CAG 00430R. And actually, you can see the details of what the requirements or volume requirements mean. And then we all have to participate in the TVT registry. We are going to consecutively enroll TAVR patients, all TAVR patients performed. We will accept all manufacturer devices according to CMS, and we will follow the patient for at least 1 year. Some of us follow the patients more than 1 year, and that's okay. It is up to your heart team how you're going to conduct your follow-up. Most of the patients will go back to their primary cardiologist for the continuous follow-up. The TVT registry is very important because it actually will tell your program performance. One of the ways that your patients can actually see your program performance is actually the reported rolling 3-year STAR data. And the rolling 3-year STAR data actually includes the 5 quality domains that are hierarchical and multi-categorial. And those are your mortality or 30-day mortality, 30-day stroke, major or life-threatening bleed, renal failure or AKI, and aortic paravalvular regurgitation and the severity of it. Your STAR rating is actually reported as site difference. It is risk standardized, or you are compared to the alike sites. Like if you are doing 150 cases, you will be compared to the high volume sites. If you are doing less than 50 cases, you will be compared to the low volume sites. It actually has 46 variables that are documented in your patient evaluation. And then these are some of the requirements that you will actually have to meet to publicly report, but also to get your STAR rating. Public reporting is optional at this point, but it is available on findyourhearthome.org, where patients will actually go and look up your facilities and see if you are publicly reporting. Again, talking about those 5 domains, very busy slide. We're not going to go over all of it, but as a program coordinator, you should be very familiar about these definitions and what they mean and how your program will be impacted when you have adverse event. So a role of a coordinator is very complex. We, along with the patient, really are in the center of this circle when you really think about it. We walk the patient pathway from the beginning of the referral to the end of that follow-up and sometimes beyond. And, we make sure that the wheel of all of the involved stakeholders continue to keep connected and continue to keep turning because, we ensure that the patient gets actually the best care possible with the multidisciplinary heart team approach. But the coordinator role does not just stop at patient coordination and ensuring that we have a cohesive multidisciplinary team. The role is a lot more than that. We are the face of the program. We actually handle the referrals. We organize parties. We actually organize dinner events, educational events. We do billing and coding. We document, we make sure that all the charts are correctly submitted. So there's just so much that we do within the program. It is a very complex role, but for those of us who have done it for many years, we just love doing it. And the reward that we get from the patient is incredible. So we're going to move into a case study and kind of look how the coordinators present to patients, how do we gather all the data, and how do we present, our patients at a heart team case conference. So in this particular case, this is an 85-year-old female. She presented to us with NYHA class 3 with the symptoms of dyspnea and exertion. She has fatigue, she has decreased functional capacity. And actually, she came to our clinic with her daughter, who validates all of her symptoms were true and very concerning. They've been going on for the last 6 months. She's been actually undergone multiple evaluations and was referred to the structural heart clinic for further assessment and heart team recommendation. She has an SDS risk score of 2.82%, and she is actually 2 out of 4 frail. So when we presented the case, we decided that actually a patient is high risk based on the SDS and 2 out of 4 frailty. She was frail by the 5-meter walk test, by the grip strength. She is able to take care of her daily activities that independently. She does not need any assistance with those, and her albumin was 4. She has a history of course, severe symptomatic aortic stenosis. She also had a mitral valve replacement with a mechanical valve. She has CAD. She had multiple stents. She has 6 sinus syndrome and recently received a pacemaker prior to the TAVI procedure. She also has paroxysmal atrial fibrillation, CKD stage 3B, bilateral lower claudication. So she's a very complex lady. And talking about those multiple comorbidities, obviously she checked a lot of those. So we did not just meet high-risk indication based on the frailty. We also have multiple comorbidities. Her echo was done and her AVA was 0.5 centimeters squared. Her mean gradient is 33. The peak velocity was 3.72 meters per second. Preserved ejection fraction at 55%. Her RVSB was 35, and her stroke volume index is 25 milliliters per meter square, with the AVVR or velocity ratio of 0.16. And she does not have any major other valvular heart disease. So we actually deemed this patient to be actually a D3 criteria based on the above measurements. This is her heart catheterization results. Again, at the time when we did her EKG, she had sinus rhythm with first-degree AV block, but at that time she already had a pacemaker, but she did not require it at this point. She had no carotid stenosis. She had good lungs with an FEV1 of 83% predicted. And these are her labs with a creatinine of 1.3 and a GFR of 40.3. So our procedure plan was that she is a high risk, that we use shared decision-making process through cardiosmart.org to have the conversation with her around medical management and TAVR. Surgery was not the best option for her at this point, but we focused on the medical management and the TAVR. As a team, we decided that she would be a moderate sedation, and our actually selected valve is a 27 millimeter Navitor with a right transfemoral axis, percutaneous with 15 French, and we were going to pre-dilate her valve. So again, here is her cardiac study. You can also see her echo and the EKG. We actually, this is a snapshot of the CTA that we reviewed. Now, of course, we go in a lot more details, looking at the annulus, looking at actually the LVOT, look at the sinuses, the coronary heights. We look at her axis. Now, she did have a pretty borderline axis. However, she did really well with the right transfemoral axis. So that was a very good decision for her because it did allow her to have a faster recovery. So post-TAVR procedure, she went to recovery. She actually went to PACU. She went to a step-down unit after being recovered in PACU. And post-TAVI measurements before discharge, her AVA was 2.39 centimeters squared. She had an AVV max of 1.42. Her EF was at 50%, slightly lower than where we started. The mean gradient was 4 and the peak gradient was 8, and no paravalvular leak. She was discharged on post-op day 2 because she did have some anesthesia left effect, residual. So we did keep her one more day just to make sure that she will be able to go home and take care of her independently. She did go home on post-op day 2. She did not have any major adverse events. She had stable hemoglobin, creatinine. We ordered her phase 2 cardiac rehab, which she did sign up, when we followed up with her on her 30-day follow-up. And when we look at her 30-day follow-up, her KCCQ score was, and this is an overall score, is 58 with an increase in 17 points. So she went from the class 3 heart failure to class 1. She had no rehospitalization at that time. And this was her echo at 30-day follow-up. So her gradient still remained in the single digit with a mean gradient of 6. Looking at one of our other patients, so this is a 77-year-old male. He presented to us, with exercise intolerance and pedal edema. He had NYHA class 2, and his actually KCCQ score was at 60. So he actually had some limitations with fatigue and pedal edema, but he did not have a lot of symptoms. So, based on that, we classified him as class 2. He actually had 1 out of 4 frailty. His grip strength was at 30 based on his BMI. That would be considered frail. And his SDS score was 3.05%. So we deemed him high risk based on his 1 frailty and SDS risk score at age 77. His AVA was 0.7, mean gradient 47, peak velocity 4.51, EF 55 to 60. RVSP was at 42, and he had mild to moderate MR, and then also moderate TR. His this is his heart catheterization. So he did have a RCA stenosis that was STEMI 3. So he did have some scattered coronary artery disease that we felt did not need to be addressed prior to the TAVI procedure. His EF was 60 to 65%, mean gradient between 50 and 55, and AVA 1. His PA pressure was here also 45. His EKG shows AFib with occasional V-pace complexes. He has no significant bilateral stenosis. He has FEV1 58%. These are his labs with a creatinine of 1.9 and a GFR of 36.1. And again, when we look at the comorbidities, he does have some comorbidities that also swayed us into calling him high risk. So based on his echo findings, he is a B1 severe symptomatic aortic stenosis criteria, high risk based on the SDS1 frailty and multiple comorbidities. Again, we always use our shared decision-making tool, cardiosmart.org, to make any discussions with the patients and allow patients to do their own research. We also opted for this patient to have moderate sedation, and our approach was right transfemoral percutaneous with 15 French, utilizing 35 millimeter Navitor valve, and we actually did opt to pre and post dilate this patient just because of the heavy calcification in his aortic valve. And again, looking at his coronaries, you can see his leadless pacemaker there. Again, decent images on the echocardiogram. There were multiple images that were taken. And of course, again, we see the V-paced EKG. CTA showing also the LVOT calcification that he has. His perimeter was 92. The sinuses were big. And again, access was adequate for the right transfemoral access. So this patient also went to PACU step-down unit. His post-procedure measurements pre-discharge were AVA 2.45, Vmax 1.53, AVA 1.73, EF was 55, mean gradient 5, and max or P gradient 9, and trivial PVL. So he went home next day, no adverse events, also got an order for phase 2 cardiac rehab, and did really well, up until also our follow-up at 30 days. KCCQ score did increase 4 points. We really didn't have a lot of room to improve, but we did improve some to 64, and NYHA1, no rehospitalization. And if you look at his echocardiogram, again, he maintained that mean gradient of 6 at 30-day follow-up. So at this point, we will open for discussion and allow for questions. I don't know, Dr. Galoo, if you're back, I can stop sharing my screen and we can start having a discussion.
Yes, thank you so much for that excellent presentation and also for going through those cases. It's always very helpful to actually be able to see in action what you presented. There's a question I'd like to ask you, and this is about how you conduct your heart team meetings. This also addresses one of the questions in the chat. When your heart team reviews the case and looks at clinical and anatomic considerations, how do they decide on which valve they're going to use? What are some of the things that you look at?
Yeah, so I apologize. So what is really important for our team is that actually when we review these cases, which in this presentation, you only saw me presenting the Navitor workup, we actually present all of the 3 commercially available valves that we have for patient selection, and the heart team will review all of them and make that decision. Sometimes, again, depending on the anatomy, depending on, some other features, but I really think for the sites that use Navitor currently, our high-risk indication is really based on just or selection of Navitor is based on the high-risk indication. We're not necessarily looking for the anatomical features or anything in particular, because, again, the benefit of having all of the 3 technologies is that we can treat multiple different anatomical patients, right, and anatomies. So we don't have to necessarily worry about that. But we actually do look at the high-risk patients. I also want to mention that one of my sites is also part of the Envision trial. So they actually have the luxury to actually offer this patient to offer this, therapy to the patients who are not just high risk, but actually a low risk and intermediate risk.
Yeah, that's great. Thank you so much for sharing that. As you pointed out very nicely, that presently in the U.S., the valve Navitor, specific Navitor with Vision technology, is approved for high-risk patients, but there is an ongoing trial, and we hope to get it approved pending the results and outcome review, of course. We hope to get it approved for low and intermediate risk trials. If you could give us a little bit of information or your approach, when do you think Navitor works well for a patient outside of the risk profile? Are there features of the valve that you find or that you look at that may favor a patient, or just in general, where do you find this valve sort of excels?
Interestingly, you asked that question because I think the first question that we always ask ourselves, what is going to be that lifetime management? So not just looking at necessarily the anatomical features of the patient, but also what is that patient going to need in the future? Is the patient younger, right? Do they have coronary disease? Will they have future reintervention need of the valve? What that reintervention will look like? Are we going to do a valve in valve? How big is that valve? Looking at the small annuli, very important topic, as it has been in the discussion for a while, understanding, which patients should get what, right? And which valve, which technology is best suitable for the small annuli for women. So we take all of that into consideration and, try to determine, based on the current knowledge, what we know today, what would be the best option for the patients if we had a crystal ball knowing what's going to happen to them in the next 5, 10, 15 years. So that's usually how we go about it. It's also sometimes the physician experience, what they know will work best in certain patients. And sometimes that's a very powerful decision-making tool in our heart teams. What do physicians know that works well? And that's how they're also going to select, certain technology, and that's how we select Navitor.
Yeah, well, thank you so much for those insights. Certainly, I think in the early days of TAVI, it was basically get the valve in and that was a success. But I think since then it's gone from a game of checkers to a game of chess. You have to think of so many things now. You have to think of coronary access. You have to think about also lifetime management. What implications is your valve choice going to have on the future for the patients, such as if they need a valve and valve, what is your neosquirt height going to be? Certainly all those things are important considerations, and we think Navitor is well placed for that. So going on to another question I wanted to ask you, and that is for valve coordinators who are new in their role, do you have any kind of, based on the experience and all the patients you've taken care of, any wisdoms or any pearls you'd like to share for new valve coordinators? I know one of our questions was from a new valve coordinator. Eileen Pham asked a similar question. When you're running your meetings, do you present all the images? So if you could answer that question, but also just general pearls of wisdom.
Yeah, absolutely. Well, listen, I've been in the shoes of the valve clinic coordinator in the beginning of when the valve clinic coordinator role was created. And I recognize that can be very overwhelming and truly underappreciated from somebody who has never stepped in those shoes. This role encompasses everything from taking care of patients to secretarial duties to actually navigating the whole team, being the office manager sometimes. And if you have providers that do the same thing, they also have to be providers and see patients. It's really important in the beginning that, number one, you have the knowledge and the training to take on taking care of these complex patients, understanding the guidelines, understanding the disease process. Knowing your resources within the facility is really important. And I will tell you, I'm actually the lead for the structural heart work group at ACC. And a big thing that I will take a message from that group is you have to have a friend. You have to have somebody who you can call and ask questions. And if you are in doubt, there has to be somebody who you can give a call and say, okay, I know what I'm supposed to do, but I really need to just run this by somebody to make sure I am not missing something very important. So finding that friend in this big community of the valve clinic coordinators, it's really important. And I strongly urge you, if you are a new valve clinic coordinator, you have to find yourself a professional home as well. So whatever that is, that's where you're going to find peers that you can actually lean on that can help you if you don't have anybody at a facility. So that is that. And then talking about how we run the case conference. Well, I just presented a sample of our case conference. And we, in our case conferences, we still use a formal presentation on our patients. Good or bad, we still do it. And we actually go through all the testing. We go through all the images, everything that's available on the patient, and allow the heart team to review it. And sometimes it goes very quickly because it's slam dunk, it's easy, there's not a lot of questions. And sometimes there will be a lot of questions because there will be a heart team member that will pick up on something that maybe we did not. And that's the beauty of having the multidisciplinary heart team, is really looking out for the patient, making sure that we eliminate as many unknowns as possible. So when we go into that procedure, that the procedure is successful and the patient goes home feeling better. So yes, we do actually present every detail of those cases. And again, on complex patients, listen, we have M-tier patients as well in our case conferences. And again, tying in a true structural heart coordinator, not just taking care of the TAVR patients, but taking care of other, mitral patients, tricuspid patients, pulmonic, maybe ASDs and VSDs or PFOs, like all of those are part of your structural heart clinic. you actually have a multidisciplinary team that is extremely knowledgeable, and they will go through some of those complex images and make sure that we are treating the right patient population, that we have not omitted doing something in efforts to maybe go through the process as quickly as possible. So, there are safety checks and balances within that heart team, and you have to build your heart team to do that. It doesn't come, like that. You have to train your heart team to be committed, to dedicate their time to the heart team meetings, and to be involved.
Well, that's a great answer. And, I think you guys are doing it absolutely the right way. You need to be meticulous and methodical when you review these cases so you don't miss anything. And I think in the case of the coordinator's role, I think it's very important in that scenario as well, because you may have a large hospital system may have 3 or 4 TAVI operators and 3 or 4 surgeons. And the consistent presence, of course, the heart team meeting is always going to have an interventional cardiologist, always going to have a heart surgeon, and oftentimes a radiologist and other physicians as well. However, they may not necessarily be the most consistent presence in the heart team. And this is really where the coordinator comes in, and they can be the truth teller. They can make sure that the process is consistent and that the same process is applied to every single patient. So I think it's a great answer you gave, and it's a great approach you all have. Going to the chat box here, I think we've answered some of these questions in one way or another. And then there's a new question just popped up, and he's curious about other heart teams. How often do you meet? How many patients are presented at each meeting? And then the average length of discussion per patient. I'm sure that varies depending on the complexity, but I'll let you answer that question.
Yes, absolutely. That's a great question. So actually, I have heart teams that meet at least at a minimum once a week to discuss patients, and it really depends on how many patients we have. I actually have heart teams that will meet for an hour, and they will utilize that hour to discuss 10 patients because we have so many to present, right? Again, we take time to present patients as long as the heart team needs, depending on the complexity of the patients. I just mentioned that earlier. There will be patients that we bring to the discussion that will be picked apart. They will actually carry a lot of complex diseases, anatomies. Usually anatomically, this is where we make a lot of discussions on what would be the best. And so your heart team has to be comfortable with that process, and that's how you're going to determine whether you need to meet once a week, whether you need to meet every 2 weeks, because again, we also don't want to create heart team fatigue. If you don't have patients to meet every week, then meet every other week. And if you do have patients that need to be done, you can always create ad hoc meetings, bring everybody together. We do that also for our emergent cases that cannot wait for the regular case conference. We will create ad hoc cases to present those as well. Okay, so it looks like here, I'll call one of the questions is, what does your TAVR workup look like from referral? Do you have the patient get all the testing before their consult, or try to combine consult testing to decrease the amount of appointments the patients have to come to? That's a great question. Again, a lot of times we make that decision based on, what the patient will tolerate. If the patient requires multiple trips and they don't have good transportation, then we will try to arrange everything at once. So they will actually come, have the testing on one day. They'll see the cardiac surgeon. A lot of times the patients have already seen interventional cardiologists, so that interventional cardiologist might have already referred the patient after they saw the patient. But if they did not, if the referral came from one of their partners that is not performing TAVR procedure, we will actually schedule sometimes the day when the patient will see both physicians on the same day. It really depends on the setting of your clinic. We have several different variations. We have bricks and mortar clinic. We actually have virtual clinics where I have my APPs and my nurses as structural heart navigators. They actually have the workups that they do, but then the patients will go see physicians independently. It really is, there's no right or wrong answer. It's what's going to work best for your team, what's going to work best for your patients, and what's going to actually reduce that what's gonna actually reduce that burden on the patient and the family as well. So you just try to work the best you can from the resources that you have. So that's a great question. Okay. So if nobody else has any questions, I'm going to take a look at the chat one more time. Again, I greatly appreciate everybody joining the webinar today. It was I really appreciate Abbott sponsoring and helping us with the education. I'll kind of hang on just a little bit longer, but if we don't get any more questions, we are going to go ahead and close the meeting. Again, thank you everybody for joining, for finding time out of your busy family schedule, your work schedule, depending on where you are today. Really appreciate you all joining. I see
Thank
Dr.
you.
Galou is back.
Yeah.
Hi.
Sorry, I'm not sure what happened. My computer just abruptly shut off. So apologies for that. But hey, this was a great coordinators meeting, and it's a great presentation. Your knowledge really is impressive. And they're actually very lucky to have you down in the West Florida division. And anyone that heard this webinar today, this is the right way to do it. So thank you so much, Yasmina. We really appreciate it. And thanks, as I've already thanked everyone. Thank you, everyone, for joining. We look forward to seeing you on future programs, and have a great evening.